Okay, so this one, Unit 6, will comprise of Chapter 19, Chapter 20, and Chapter 23. So this unit talks about residents with special needs. We are going to get into talking more about the systems of the body. I will not go into details with that because it's really, some of the details are really not necessary, but you still need to know them. So whenever you work at your different facilities that you'll be working at, you will have a care plan. I think I've talked about care plans already. So this is what your care plan sometimes will look like depending on the facility that you are working. So they will talk about the problem, and they'll talk about what they want to achieve at the end of it all, and then what interventions they are. So for example, this person has got short-term memory because they had a stroke, and then the goal is to have this person use the activity calendar to select activities of daily living. And then the intervention will be place the calendar where they can see it, when you can do AMKs to please, show him so that he is very familiar. And then throughout the day, you remind Paul of the activities that he planned to attend for the day and assist with finding the event. When you discuss plans with your resident, they are more likely to do it than when you just tell them, this is what you need to do. They will resist. You saw in the video about the bathing. When you plan with the resident about bathing, give them the chance to choose what time they want to, especially those that will resist bathing. Ask them what time they prefer to bathe. Do they prefer to bathe in the morning, or do they prefer to bathe in the evening? And then when they make a choice, it's very easy for you to go and say, hey, Mrs. Smith, you said that you bathe in the evening. It's now evening. Can we go do the bath? They will probably go with you. Then, you have to give them that authority to be in control. And then any other activities that the resident will want to do, just discuss with them. So we will look at various systems of the body. We'll look at the secretory system. This is just your blood carrying nutrients and oxygen, heart muscle that pumps the blood vessels, the circulation, you have the veins, arteries, and capillary veins. So we are not going to go into such details about that, but you still be expected to know what those are. So this is just an image showing how your circulatory system goes like. Those of you who will go further into nursing, you will learn into details with all that. So the functions of the circulatory system, one of the functions is to carry oxygen and carbon dioxide. That is on the blood side. And then on the heart side, it's pumping for circulating blood. So then you have all those different aspects that you have to look at. And this is just another image of how the blood circulates in your system. That's still the functions of the blood vessels: dilate and contract, controls body temperature, transports blood, make sure that the gas and the nutrients exchange happen during the circulatory system. What causes the pulse beat? Each heartbeat as it pumps blood, the expansions of the arteries, and heart pumps in steady rhythm. This is in a person that is normal. If you have heart conditions, then you are more likely to have a heart attack. When the circulatory system is not working well, you may have a heart attack. People whose circulatory system does not function very well, they will suffer from high blood pressure, they may have blood clots, and they may have congestive heart failure or heart rhythm disorders. Signs and symptoms: you may see shortness of breath, you may see chest pain, you may see edema, especially in the lower extremities, like their feet and their legs are swollen because the circulatory system is not functioning well. As a result, they accumulate a lot of fluid in their system. And poor circulation. And then sometimes you may see cyanosis. When the blood doesn't circulate properly, some parts of the body are not receiving that blood, then you may see some cyanosis. Cyanosis is when you notice that maybe the hands or the feet turn blue because the circulation is not going as it's supposed to be in a normal person. So when you care for people who have got this circulatory, the circulatory system is not working properly, some of the nursing care, they will be on medications, they will be on special diets like a low fat, low salt, low cholesterol. This is when you serve food and their diet will probably say low sodium, low fat, and low cholesterol. So the dietary people know that this person has got a cardiac problem, and they'll know what kind of a diet to give them. If your resident is on a fluid restriction because of their cardiac system not working properly, there will be how you give them the fluids. Say, for instance, on morning shift, say, for instance, they have, during 24-hour period, they can only take maybe 1,000 cc's of water for a 24-hour period. So then you can imagine there are 3 shifts in one day. There's the morning shift, there's the evening shift, and then there's the night shift. So between the 3 shifts, you will divide how much water your resident can take. So we'll probably say 400 cc's in the morning. So you will give them 400 cc's. If they're a type of resident that will drink a glass of water all at once, you may want to give them little by little. But if they are able to control how much they drink water, you can give them, for your 8-hour shift, you can give them the 400. And if they drink it all, then they cannot have any until second shift when they get their other 400. And then overnight they can get 200. So that's how it would be divided if your patient was, or your resident was on a fluid restriction. And when they are on a fluid restriction, you have to accurately document how much they've drunk and how much they've had out, like voiding, how much pee have they had during your shift. You have to be taking their weights daily so that we can know if they are retaining too much fluid. If a resident accumulates a lot of fluid in their system and you weigh them, they will probably gain like 5 pounds in one day. That is an indicator that they are retaining a lot of fluid. So people with circulatory system or cardiac problems, when they have a wound, especially in the lower extremities, like under their feet or on their legs, the wound will take long to heal because that area is not receiving enough blood to help them heal. So they will heal slowly. So you have to be very protective, making sure that you protect them from injury so that they do not have any cuts or develop any wounds. And then you have to elevate their swollen feet. Like when they're sleeping, you have to elevate their legs on a pillow so that that fluid is not pulling down to their extremities. The other system that we'll look at is the respiratory system. This is more of your nose, throat, the pharynx, or your throat, the larynx, the trachea, the bronchial. So these ones will have a lot of respiratory problems. And some respiratory problems will be like coughing, sneezing, COPD, respiratory infections. So the functions of your respiratory system is to make sure that the body gets the necessary oxygen, you get enough oxygen, and then you release the carbon dioxide. The respiratory system also works hand in hand with the circulatory system because you are talking about heart pumping the blood to circulate through the lungs, and it carries oxygen to all areas of the body. So the circulatory system and the respiratory system kind of work hand in hand. Conditions that will affect the respiratory system, allergies, smoking, upper respiratory infections like the lung infections, obesity, people who are overweight, sometimes it's hard for them to breathe, like even just climbing up the stairs when you are an obese person becomes so hard. By the time you reach up to the top of the stairs, you are huffing and puffing because of breathing problems. And people who are paralyzed or are quadriplegic, like their limbs do not work, they have respiratory system conditions that affect them. Diseases with the respiratory systems are the asthma, emphysema, bronchitis, some cancer. You can have cancer of the lungs. Chronic pneumonias, you're constantly having pneumonia. COPD, tuberculosis, and autoimmune conditions such as AIDS, ALS, MS, and muscular dystrophy. Signs and symptoms: if a person has got respiratory problems, you see them labored breathing, like if you climbed up the stairs and you are overweight, you labor in breathing. Coughing, wheezing. We talked about cyanosis because the circulation is not good. Thick secretions. You'll probably be breathing through your mouth. Rapid and shallow breathing, slow breathing, dry lips and dry mucous membranes. Some nursing care that you can do with somebody with respiratory problems is medications, and then also making sure that they are sitting upright in an upright position. Usually people with respiratory problems do not even like sleeping on the bed. They would rather sleep in the recliner because then they can breathe well. When they lay down flat on the bed, they have difficulty sleeping. So you will see a lot of people or a lot of residents who would rather sleep in the recliner. Always maintain a quiet environment for them and a slow pace on doing things. Don't rush them, because if you rush them, they start panicking, and with the panicking, they'll stop breathing. Some of them will literally stop breathing because you are rushing them. So anybody with a respiratory problem, don't rush them through anything. Take it easy. And then you can also provide oxygen. Sometimes they'll have to require extra oxygen. Another system that we'll look at is your gastrointestinal system, which is your stomach and your bowel. Small intestine, large intestine, and the anus, which is the outer opening. I think you have this table in your book, just go through it. Your small intestine, which does most of the absorption, and then the large intestine. After the small intestine has done its job, it has absorbed all the nutrients that you need. What it doesn't need will go into the large intestine, and eventually there's excretion. Reason for chronic GI problems. These are some of the reasons why people have gastrointestinal problems. Medications, they take a lot of medications. Inadequate fluids, poor diet. Sometimes it's just other medical conditions that they have. People who do not move around a lot, and people who have poor bowel habits. Poor bowel habits may not necessarily be their fault. It's because of the other medical conditions that they have. They are constantly constipated. Some of them can be loss of bowel and muscle control, and some of them can be poor positioning. So constipation is one of the signs and symptoms that you see with the poor gastrointestinal issues. Their abdomen will look full and distended. They'll kind of have a big bowel belly. If they've had no bowel movement for 3 days or more, they may need some medication to help them have a bowel movement. They may have nausea and vomiting, and their stool can be hard because they haven't, they're constipated, and it's hard for them to pass bowel, have a bowel movement. And then untreated constipation can lead to fecal compaction. So if somebody hasn't had a bowel movement for more than 3 days, A lot of facilities, because you are recording every single day and on every single shift, if 3 days has gone by and they haven't had a bowel movement, a lot of facilities use a software on the computer that will trigger that this person hasn't had a bowel movement for 3 days. And then they'll probably get some help either by giving them a laxative so that they can have a bowel movement. If more than 3 days go by, nobody has not noticed, not said anything about it. If somebody goes for more than 3, 4, 5 days without having a bowel movement, you can imagine how much stool stays into their system. Some people will probably end up going to the hospital, or otherwise you may have to use an enema to have them get that stool out. So it's always very important when you work to report that Mrs. Smith or Mr. Smith has not had a bowel movement today. The next day will be the same report. The third day, they should be getting some help.
What is that other word up there next to appetite? Loss of appetite and what?
Malaise. Malaise is when you just kind of feel, it's a lazy kind of feeling, but you cannot control it. So if they end up having an enema, as a CNA, you assist the nurse, because having to do an enema is not really a very pleasant situation, and it's not easy for one person to do it. So you may have to assist your nurse by supporting the resident. You just be supportive, because it can be a very unpleasant situation and the resident might not want to do it. But if you are there as a nursing assistant giving them that support, it can go way much better. Comfort the resident during and after, help them to the bedpan or to the commode, and then just observe and record the results. So prevention of constipation, observe bowel movement and toileting habits. Like I said, during your shift, you have to make sure you report that they've had a bowel movement, and if they haven't, you say something. Observe and record bowel movement, amount, consistency, frequency, and the color. Encourage dietary habits. Make sure they are eating fruits and vegetables. Make sure you're giving them fluids. And also limit constipating foods. Don't give them a lot of candy. Candy makes you constipated. Give them healthy foods. That way you can prevent it. So sometimes when people have lost the muscle or the natural bowel movement condition, sometimes they end up with what is called an colostomy or ileostomy. They will have an opening in their intestines, and instead of going to the bathroom the normal way, they will have the bag here, and that's where the fecal matter will go. You know, there's so many things that cause that. Sometimes you may have a bowel obstruction, and you go for surgery, and then they'll have an opening. And sometimes when that is resolved, they can go close you up, and you can go back to the normal elimination of a bowel. But some people end up with that for the rest of their lives. So, so their feces will come through the stoma.
Does it make a difference which side that colostomy is on?
Usually it will always be on the, you know, you see how your intestines are over here, because this is the way our intestines go, like that. So usually it will be around that area. So you will see an opening like this, right here. I think with some of the mannequins that we've had, you've seen those little red things on their stomach. That's how it would look like on a real person when they have an opening. It's like that.
It's thick.
Huh?
It's thick.
Oh.
My friend got shot and he had to have one on him. And for some reason, the bag used to always bust.
Because he was keeping it way too full for too long.
Yeah,
So when you are in the facility, that's some of the things that you will be working with. If a person has a colostomy bag, it's up to the nursing staff to make sure that it doesn't stay too full. Otherwise, then it creates work for you, because if it's too full and it bursts open, you still need to clean them up. So just make sure you're constantly checking them. And there are some residents who've like had it for life, for a long time. They know how to take care of it. So you'd empty it and just clean them up, close it up. That's part of the training that you would do at that particular facility. If you have a person with a colostomy bag, they will teach you how to do that. In the CNA classroom, we talk about it, but we don't teach you how to do it. But those of you who will go to nursing, you will learn how to do that. So that's just how the colostomy opens section from the colon into the abdomen wall. And then the ileostomy is an open section from the ileum, which is like from your stomach, even before it goes into your intestines. The ileostomy will come right there. So ileostomy, the stool will be more liquid because it hasn't been through the small intestine to absorb the liquid, because it's like right by the small intestine. So before the intestines even absorbs a lot of the fluid that you have, the stomach will be right there. And so it will be more liquid than a colostomy. An ileostomy is difficult to control and regulate. And then the stool more caustic to skin around the stomach because it has a lot of acid before it absorbs a lot of it. So when it's on the skin, on the outer skin, it can burn you. So you really have to be very, the acid in your stomach can cause some damage on the outer skin. So if a person has an ileostomy, you really have to take good care of them. Colostomy, the stool is more formed and less watery because the small intestine has absorbed a lot of liquid by then. It's easier to regulate and control, and cleaning of skin around the stomach is very important. So for both the ileostomy and the colostomy, cleaning around the skin is really very important. So this is how the appliances look like. So the stool, on this part here, where you see the more orange, that's what goes onto the skin. Mm-hmm. And then this is how it shows. This is like this one is what you'll be able to see from the outer side. This part here is from to the skin. So even on this one will go on the skin, and this is what it will look like on the outside. So the opening is at the bottom. So you close it with this little thing. Here, this one has a Velcro. So once you open it, you'll be cleaning the opening. You clean it, and then you fold it back again.
How long will they keep a bag? How many days?
Some people are able to keep the bag for a week or so. If you are helping them clean it up properly, it will stay. Because you can imagine this part here has got an adhesive. This is an adhesive that sticks to the skin. So the more you rip it off and put it back again, the skin is irritated. So the more you keep it, the longer you keep it, the better. So, but it also depends on how well you are helping the resident, okay? Because they can leak. If you're keeping the bag too full, either it will burst open, or when it's too full, and when they lay down, there might be some leakage around. So then you have to take it off because now everything is leaking from the side. So it's very important if you have a resident that has got a colostomy bag, please take good care of them. So individuals with ostomies, skin around the stoma, functioning of ostomy, stool every day, irrigate if it needs, you can irrigate it, like clean it out nicely, encourage fluids so that they can have the stool can come out. And then also know, just imagine if you would have a colostomy bag, how would you feel if you had a colostomy bag? What else? Uncomfortable, embarrassing. So you are the support for your resident, because otherwise you can just imagine how uncomfortable, it's embarrassing. It changes their image. It's like they're so conscious of it. Even when they're dressed up, they might be thinking, oh, if I go out in public, what about if it bursts open? So that's why we are to be very supportive, make sure, especially when they are going out for an activity, please clean them, make sure their ostomy bag is clean, it's empty, so that by the time they come back, it's not too full, okay? And then just do not pass judgment on them. Nutritional imbalances. We talked about nutrition as to, some of the things that we need to take care of with nutritional imbalances. Heredity, congenital, physical swallowing difficulty, poor dentures. They can be, some of it can be mental, they're depressed, or they have anorexia. So these are some of the things that we have to make sure we are taking care of so that we do not cause any malnutrition for our residents. Signs and symptoms would be underweight, malnourished, muscle wasting, chronically sick, vomiting, and diarrhea. Other GI conditions, that's still your gastrointestinal conditions, cancer, GI tract diseases, irritable bowel syndrome. Irritable bowel syndrome is like whenever you eat something, your bowel gets irritated and the food comes out. And enzymes affect complete digestion. Some people do not have the natural enzymes that would digest the food. So sometimes you find that they are given some enzymes in a tablet form so that it can help with the completion of digestion. Diabetes is another one that can contribute. These are some of the factors that contribute to type 2 diabetes. Smoking, just sitting down, not doing anything for hours and hours. You just lay on the couch and watch TV. When you're overweight, high cholesterol and high fat foods can cause diabetes. And high blood pressure can also cause diabetes. Smoking, it affects a lot of other things in your system, such that then you're not able to break down the glucose in you do not use your glucose properly in your body. So that can cause diabetes. High blood sugars is another term for a high level of blood sugar is called hyperglycemia. And then a low blood sugar is called hypoglycemia. So some of the symptoms, like you will have residents who have got diabetes in your facilities, and these are some of the signs and symptoms that you have to look for. When their blood sugar is high, they will have a flushed, warm, dry skin. They will be nauseated. They will be going to the bathroom frequently. Their thirst will increase because they want to drink more and more water. And their breath will smell fruity. And I think one of the most common breath is like a pineapple breath. So when you notice things like this in a resident whom you know has got diabetes, you need to report that immediately. And then if their blood sugar is low, they will be sweaty, their skin will be cool, they'll be hungry, they'll be wanting to eat constantly, they'll be jittery, they'll be shaking, they'll be restless. So those are some of the things. They'll have a double vision, or they'll be confused. Confusion is one of them that you can easily notice when your resident has got a low blood sugar. So immediately you have to report to the nurse that, looks like the resident is having a problem with their blood sugar. Do you mind going to check their blood sugar? And if it's low, you immediately give them something to boost their blood sugar up. You will know your resident, and some of the things will just easily show. I'm trying to think. High anxiety. So what to do? Report signs and symptoms you observe to nurse. Help in observation of results of interventions. So like if they had a low blood sugar, you probably give them a cup of orange juice. Maybe you even add in some sugar so that the blood sugar can get up to within normal limits. And then you can report the results. So I think Mrs. Smith looks way much better. They are no longer confused. It's because their blood sugar has gone up to within normal limits. And then document nutritional intake. Prevention and treatment, measured dietary regime and compliance, quiet environment, fluids, make sure they are drinking. They can either be on insulin, so make sure they are getting their insulin at the right time. Oral, hypoglycemic. Some people do not take, some people are not like necessarily on insulin, but they will take a diabetes pill. They kind of take in a tablet form. And then others can be, you just make sure they have a snack. Diabetic people need to have a snack even at bedtime because their blood sugar might drop during the night. And then good skin and foot care. People with diabetes, they do not heal very well. Their wounds, especially at the bottom of their feet, they do not heal very well. So you really have to make sure you're taking good care of them. Complications of diabetes can cause kidney failure, heart disease, circulation is slow. Their wounds will heal slowly, and some of them they'll end up with no healing at all, and they'll they'll have to have their limbs amputated. They'll either amputate their foot or they'll amputate their leg below the knee, and some people it will be above the knee. And then they also get into eye problems. A lot of them end up being blind because of diabetes. Urinary system is another one that we have to take care of. Get rid of the waste in our body, fluid and electrolyte balance. Imbalance will cause fluid retention. Fluid imbalance will cause fluid retention, and as a result, you see a lot of swelling in their legs, especially. The kidneys will be unable to filter water from the body. There will be a sodium and potassium imbalance, and then excessive loss of fluids, like if they have diarrhea and vomiting. Conditions impacting fluid and electrolyte imbalance will be loss of appetite, low fluid intake, depression, dementia, and loneliness. You know, when somebody is depressed and lonely, sometimes they won't eat, and for the most part, they will also won't drink. You look frail. With the elderlies, it's always better to make sure they are drinking and they are eating well, because they may not even know that they are hungry. And especially if they have dementia, any mental illnesses or depression, they won't even care whether they've eaten or not. We've talked about fluid restrictions. So if your resident has a fluid restriction, we talked about how you can monitor intake and output. And the fluid restriction, for the most part, is ordered by the doctor. You just don't have somebody go on a fluid restriction. And for the most part, it's because they've got a cardiac problem, or they have a renal problem, or they have a brain tumor. If they have a brain tumor, or they've undergone a brain trauma, sometimes if they accumulate a lot of fluid, then it can cause a problem with their brain, retaining a lot of fluid in their skull cavity. And then those that have got liver disease also can get onto a fluid restriction. So what to do? You measure fluid intake accurately, encourage to drink all of what is provided and only what is provided. You know, there's some residents who, so if you do not document, especially when they're on a fluid restriction, you give them the 400 cc's for the morning, and you did not document that. The afternoon shift comes, the resident will claim, I have not had any drink at all since morning, because they want to drink. So if you do not document, and when you also have to report at the end of the shift, like, oh, Mrs. So-and-so has already had their 400 cc's for the morning shift. And when you know that they'll drink the whole 400 cc's at one time, try to work with them and say, I can give you 200 now, that is between 8 and 10, and then you can have the other 10 to 2 o'clock, you can have the other 200. It's to help them. Otherwise, they'll drink the 400 and then they'll start wanting more. And then some people just, I'll just drink it all. I wouldn't go with that.
But they don't do a restriction. Can they, like, I know it says like they can refuse, like, what the doctor say. Can they refuse that?
They can if they don't want to. But it's really, you need to do a lot of education so that they understand why. Okay. And if a person is on a fluid restriction, make sure you are doing frequent oral care and record all liquid intake. If a person is not to have anything by mouth, that's your NPO, right?
Yeah.
Nothing by mouth. Make sure you're doing oral care. Resident may become irritable. You can imagine you're hungry and you want to eat and somebody's telling you, no, you cannot eat. For the most part, when somebody is NPO, it's because they'll probably be going for a procedure. And for the most part, NPO will come after midnight because thinking they'll be going for a procedure in the morning, at night they are sleeping, it's not too bad. And also another time when a resident can be NPO is because it's not safe for them to swallow. If they have got swallowing problems, until that is resolved. And always explain to the resident why. Explaining is always very important. You saw in the bathing, if you do not, or anything, any procedure that you're going to do, if you do not explain, it's not gonna go very well. Remove water pitcher and food from the room. It's very tempting. They are NPO, nothing by mouth, and then you leave a pitcher of water or some food in their room. They'll feel hungry, most likely they'll eat it because they'll figure, well, nobody's gonna know, right? And then place NPO sign and note on the INO sheet. So you have to, usually there's a little sticker by the door to say NPO. Any healthcare provider who will come and look at that, they'll know, oh, this resident is not to have anything by mouth. If you do not put that on there, somebody walks, oh, Mrs. Smith, you don't have any water, I'll go grab it for you. Okay, so it's always very important that you put a sign. The musculoskeletal system, you will see arthritis, rheumatoid, osteo, autoimmune, all these conditions you will see. Physically, you will see people who have got these skeletal diseases. Congenital may be muscular dystrophy. This is like, that's how they were born. Cerebral palsy is another one. It's not their fault, and that's just how they've happened to be. Muscular dystrophy sometimes, you can be born normal, but then your muscles start losing the strength. So it's a progressive weakness and loss of muscle mass. Your muscles just waste away. There's some people who were born like that, and some people develop as they grow. Other skeletal diseases can be a fracture, which is very common in elderly people when they fall because their bones are now so brittle. They fall, they will easily break their hips. And when they are in a cast, make sure you're taking good care of the skin. Amputations, some people may end up with an amputation because of diabetes or other muscular problems. So just make sure you're taking good care of them because they need a lot of emotional and physical support. Emotional, you can imagine they had legs before, now they do not have the leg. I've taken care of residents who have lost their limbs. It's not an easy thing. So, and sometimes they'll feel like it's talking about the thumb pain, even though the limb is not there, like they amputated below the knee, they'll sometimes feel like as though their full leg is there and they're feeling pain in the foot, when the foot is actually not there. So when they've had an amputation, make sure you're checking the stump where they got the amputation, they've got a new skin on. Just make sure you're checking that area because it can easily become infected. It can easily open. So make sure you're checking for color, open areas, and drainage. And then they can have an artificial leg after they are completely healed. Problem after amputation, paralysis, ambulation limitations, coordination, balance, muscle atrophy, joint deformity, flexation contractures. So these are problems that can result as a result of amputations. Interventions, supportive care, exercise, range of motion, assistive devices, which will include artificial limbs, cane, walker, crutches. Neurological diseases, these are anything that affects your neurology functions. People have strokes, so they become dependent when having a stroke. Symptoms depend on the area of the brain that was affected. So depending on the area that was affected, you may end up with a paralysis and weakness. Some of them it's speech and visual problems, incontinency, personality changes. So as the nursing care team, we are supposed to help them with their ADLs, make sure they take care of their skin, range of motion, physical therapy, occupational therapy, and speech therapy.
So what's the TIA? You got cardiovascular accident.
And TIAs are smaller strokes. Yeah. It's not like a full-fledged stroke. Other neurological diseases, Parkinson's disease, which is kind of common. You can notice more, especially with the tremors, people who've got you've heard about famous people with Parkinson's. I think Muhammad Ali had the president, the former president, yeah, he had Parkinson's. And I think the Bush Senior also, I think so. So you will notice they have a lot of tremors, and then when they are walking, they do not really lift their feet up. They're just going with their feet like this. They shuffle. And they can be confused. So nursing care will include helping them with their ADLs, nutritional intake. You are helping, make sure you prevent falls and injuries, and then promote normal elimination. Take them to the bathroom constantly. Lead them to the bathroom. Confusion, confused residents. They say confusion is a state, not a diagnosis. So it's not a disease to be confused. It's just a state of being. So people can be disoriented, they can have delirium, short and long-term memory problems, problems with communicating thoughts, ability to listen and follow directions. Especially those of you who will probably work in dementia units, you will see that. But just because a person is confused does not mean that that is a diagnosis. Otherwise, it may be part of a different diagnosis. The confusion could be from dementia, from being delirium, or otherwise depression and schizophrenia. So that can lead to the confusion. What other condition can lead to confusion? So when somebody has a urinary tract infection, when they have a UTI, for the most part, the first symptom that you're going to see is confusion. So you will wake up, Mrs. Smith wakes up one day, she's always been okay, and all of a sudden they're so confused. You go and report to the nurse and say, hey, Mrs. Smith really looks so confused today. the first thing first they are going to test is for a UTI, because most likely that's what is caused it.
What's connection down there urinary to the brain?
Oh yeah, there is. It can travel very fast. Common causes for delirium, and this can be easily reversed. Infections, hypoxia. You know, when you do not have enough oxygen, you can become delirium. People with diabetes easily get delirious. Fluid imbalance, sometimes it can be the side effects of drugs, impaired sight or hearing, chronic pain, and relocation. When somebody relocates to a new place, sometimes they can become delirious because they do not know where things are. They are not familiar with that environment. They can be confused. You should have that table in your book. You can look at it. Dementia, which is the death of brain cells. Dementia is a very, very sad condition because your brain cells die. As a result, you cannot remember anything. And it's very sad that even your own children, you cannot even remember your own children. Alzheimer's is one of the most common type of dementia. It goes in 2 stages. You start forgetting things, confusion. Sometimes it can even affect your ambulatory. Then the end stage leads to death. So these are some of the common behaviors that you see in somebody with dementia, with Alzheimer's.
Why do they like to wander off? They just keep walking and walking.
Because they really cannot remember anything, and even the wandering that they do, they're really not aware that they are wandering. And sometimes they are looking for things that they cannot even remember what they are looking for. So they'll just be wandering around. Situation causing increased risks of behaviors. They are overtired, too much stimulation. So in residents who have got these conditions, do not have, for the most part, they are in a secluded area and they do not need a lot of commotion. A lot of commotion will lead them to being so anxious, and when they are anxious, their behaviors escalate. So you will find that some facilities, like when we go to Okno, you will find that they have a smaller living area for people who kind of have behaviors where you can take them and it's quiet. A quiet environment will kind of orient them back to, not necessarily back to normal, but their behaviors will not be like, their anxiety will come down. Yeah, it's more like their comfort zone. It's very overwhelming to take care of a person who has Alzheimer's. So you also need to take care of you as a healthcare provider. Some families take care of their own, but even them, they become overwhelmed. They need a break. Okay. Grieving and Alzheimer's, loss of self for the resident, family loss, family loss is felt more like when a family member visits, they feel at a loss because their family member cannot remember them. As a caregiver, do not be judgmental when you take care of people who have Alzheimer's. It's not their fault. So do not be judgmental. What can you do? Reduce environmental stress, assist with loss of ability to plan and think. So kind of cue them to, do not overwhelm them. Do things little by little. Give positive responses. Verbal communication, do not use long sentences or complicated language. Short words only. Simple sentences. And always identify yourself when you're taking care of them. And the other thing is, do not approach them from the back. You will just confuse them more. So when you know that Mrs. Smith is going down the hallway and you're behind them, make sure you go past them and come facing them, and then identify yourself. If you alert them looking at their back, they are walking down the hallway and you're behind them and they're, hey, Mrs. Smith, you will just get them all confused, because then they'll be looking as to who called me. They may not even know where the voice came from. So always approach them from the front. And then give them time to respond. Just because you ask them a question does not mean that you may want a response right away, but they will not give you that response right away. Even if it's just a yes, it may take time for them to respond. So your speech style, like I was talking about, speak slowly and clearly. Don't use big words and medical terms and all that. Just speak slowly and clearly. Keep pitch and tone even. Don't be threatening. Always be an even tone. Keep questions simple. If you repeat exactly. So don't ask the question in different ways. Just ask the same question, like, would you like to go to the bathroom? Would you like to go to the bathroom? If you ask, would you like to go to the bathroom? They do not respond. Don't change to, do you want to go party? They'll just be like, what are you talking about? Just use the same, repeat the same question. Give one direction at a time. If resident loses train of thought, repeat the last words to help them recall. Okay? Use proper non-verbal gestures. Be in a relaxed stance. Because if you go holding your hands like this, you will just get them all disoriented. Be at eye level and maintain eye contact. Move slowly. Move with the resident. Be conscious of facial expressions, because they'll pick on that. With the facial expression, you frighten them. So just be nice, gentle with a nice smiling face. Listen attentively. If you say you will do something, be sure you do it. If resident to resident altercation, intervene promptly and in no threatening way, because sometimes they can get into that. Make sure that you respond promptly, because they can hit on each other, or they can push some. If one of them is stronger than the other, they can push them and hurt them. Respond to emotions of words, not the words to themselves. Avoid reality orientation. Reminiscence is when let them talk about their past. It's very important for them to talk about their past. assure safety, provide visual cues. Say, for instance, you take them to the bathroom and you are going to help them with oral care. So you will take a toothbrush, maybe put some toothpaste on it and say, can we brush your teeth? They'll get it. If you just say, oh, well, I'm here and I'm going to help you brush your teeth, they have no idea what you're talking about. Take the toothbrush with the toothpaste. Can you brush your teeth? You say, oh yeah, I can do that. Because you did this with the toothbrush. If you just say, okay, I'm here, I'm gonna just have you brush your teeth, they'll just sit there. They won't do anything. So if you are going to help them put their clothes on, you kind of assist them in a certain way. Can you put on your shirt? Like you take the shirt and help them. And then buttoning up the shirt, you kind of cue them. Let's button up your shirt. And then, oh yeah, I can button up my shirt. You don't need to do that because you've cued them. If you don't cue them, you just tell them, okay, Mr. Brown, can you button up your shirt? He will just sit there. Reduce stress. Keep routine schedule. If you do things in a certain way, do it like that all the time, because if you change the routine, they'll get confused. Provide rest periods, make sure you're helping them get the rest. Reduce stimuli, make sure there's no commotion around. Provide quiet time after stressful time. Evaluate care is what we are doing working. Observe and report what works and what doesn't. If you try one method and it's not working, you as a healthcare provider team can sit down and say, hey, this is really not working for Mrs. Smith. Can we try something else? Or if it's working, then say, this is kind of working for Mrs. Smith, and everybody can adapt to that. Always observe the number of hours of sleep that they sleep. Because people with Alzheimer's, they can go for days without sleeping. I mean for days without sleeping at all.
They don't feel tired, something in the brain doesn't tell them they're tired.
Nutritional intake. Nutritional intake is also very important, because for a person with Alzheimer's, for the most part, sometimes they won't sit down at the table to eat. If they do, that's your chance to make sure they eat. But if they don't, you can come up with other methods. Finger foods. They are walking around, wandering around, get a chicken drumstick and just, hey, Mrs. Smith, I put some chicken for you. They will eat from their hands. Don't expect them to sit at the table with a knife and fork eating their macaroni and cheese. Give them a sandwich as they are walking around. Give them a sandwich, they'll eat it. Sometimes, and if they have a routine time that they can sit and eat, if you see them sitting, give them something to eat. The minute you see them sitting, that's an opportunity for them to give you something to eat or feed them. But if they are wanderers, finger foods are the best. Observe, or just kind of observe what stresses them out. You know, there's certain situations in the facility that might stress them out. Kind of observe that and evaluate, or at such and such a period of time when we have music, this stresses out Mrs. Smith. So if that's going to stress her out, that would be an opportunity. Maybe one of the aides can take them out somewhere to a quiet place. Because every time there's music, they are stressed out. So make sure that during that time, you take them out. Incontinent episodes, they are always, for the most part, people with Alzheimer's are incontinent. So the best you can do is just always, when you see them walking around, accompany them, and as you accompany them, you probably say, hey, how about if we go to the bathroom? Okay, make sure you're offering them the bathroom, because on their own, they will not remember that they need to go to the bathroom. So they will have accidents all the time. Then you should also evaluate the change in functioning, because as the disease progresses, things change. So you need to be aware of that and observe and report and evaluate. Activities, focus on maintaining abilities, maintain what they can still do, just maintain that, because eventually they will lose it. But whatever it is, please maintain it that they are able to do. A 6-hour training is required yearly to work with dementia individuals. So this is all with the individual facility where you'll be working. Every year you will have to do a dementia training. So if there are updates, if there are changes, you get to know about that. Treat an adult as an adult, praise and encourage. Divide ADLs into smaller units. Okay, don't do everything all at one go. For the most part, it will not work. So if you're able to get them up in the morning, brush their teeth and wash their face, well and good. Do other things later. Don't try to do all ADLs at the same time. They become overwhelmed and they can become combative. Promote independence, like I talked about. If they're still able to brush their teeth, cue them and they can brush their teeth, and then just help them as needed. Encourage socialization, like if there's something that they like to do, if they like to play cards, if they like to play bingo, just encourage. And be patient. You need, if there's one place where your patience will be tried the most, is with the elderly people. Sometimes they'll ask you the same question over and over. No matter how many times you've answered it, they'll keep asking you the same question. So be patient, and then follow the plan of care that the team has come up with. Mental illness includes depression and mood disorders. Some symptoms that you can see are suspicion and paranoia. People with mental illnesses and they are suspicious, they'll always be suspicious somebody has taken something from them, or somebody's coming to kill them, or somebody wants to take them or do some harm to them. People with mental illness also have a lot of anxiety. They are usually very nervous. They are fearful. Sometimes they can be withdrawn or otherwise hyperactive. Out of touch with reality. They will be talking about they went to the moon, or something out of the ordinary is what they have achieved in life. They can be delusional. Okay, they can be seeing stuff that is not there, like, oh, the rats are climbing on the wall, and you look at the one like, where are the rats? Because of their mental problems. And they can be manipulative. They can manipulate you to doing things that, or otherwise control you so that they can get all the attention. Follow the care plan, be consistent, avoid power struggle. When you are caring for somebody who has a mental illness, please do not get into a power struggle with them. If they become combative, just step away. Just step away and reapproach them later. Because the more you try to power struggle with them, the worse it will become. So when they become combative, just move away. Just step away. Try to understand and look for causes and effect. Assist as needed. treat them with respect, and use proper speech. We talked about wandering. They just purposely walk around, purposeless walking. They're at risk of injury. So just keep an eye on them. There's some residents who just wander, like they walk around the building nonstop. Just make sure you are seeing them from time to time. I know of a resident that wanders, and if it's gone like 10, 15 minutes and nobody has seen him, somebody's gonna ask, hey, have you seen Mr. Smith? You know, because sometimes with the wanderers, they can get out of the door. And I know of a resident at one of the facilities that I worked. He used to be a very good football fan. He liked going to picnic stadium, and he had Alzheimer's. At that one day, it triggered that he had to be at the football game, and he left the building. Nobody knew that he had left the building, and he found himself at picnic stadium. So when he was at picnic stadium, some people who knew him, what is he doing here? They called the police. The police, because there were some people that knew that he was at a particular facility. They called the facility and they say, hey, are you missing a resident? Because Mr. John is here at picnic. So all the staff members that were working during that shift were fired. Oh. Yeah. Because he was gone for hours. He was gone for hours, and how he got to picnic, nobody knows. But he got to picnic. So, and for the most part, facilities have got in place. They have in place things that you can use for you to be able to keep watch of your residents. They have what they call wander guards. So when you go through the door, it will trigger the door will go off. Then you know the person is trying to go out, and then you just lead them away from the door. But if for some reason there's a misfunction, they can go out. Yeah.
Yes, when I was working at Brickford, I had a place you have to stay there, and when you come in, you have to put in the code. Mm-hmm. And when you leave out, sometimes they don't have it on the box, so you have to enter the code to get out. And sometimes they will just have it online, so you can just leave out. So when you leave, it's up.
Mm-hmm. Yeah. So the system has to go off to show that either the resident is by the door, because once they come to the door, it will trigger the system and the door will buzz. So whoever is close by should rush to the door to make sure that that resident doesn't go out. But then sometimes there are visitors who do not know. They are leaving and the resident is right there. They'll leave with them. And the door will be buzzing and nobody has gotten up to go and check why the door is buzzing. That resident is gone. Yeah.
And everybody get fired for them?
Well, there has to be an investigation, and especially when the resident has gone out for like, there has to be because you have to report to state that the resident left the building. So, and you have to report to the family that the resident left the building. So when you work in a facility where they have wanderers and they've got a system in place, everybody has to be alert. It doesn't matter who, it doesn't necessarily have to be a CNA to make sure that nobody has left. It's the responsibility of everybody. As soon as you hear the door buzz, you should be heading to the door. Yeah. Verbal and physical abuse. Please do not threaten or curse or scream, because then you just get them all confused, or otherwise you may have the situation escalate. Hitting, kicking, biting, and throwing, just step away, okay? Disruptive behavior, sometimes they cannot be harmful, but they can be annoying. So another resident might get annoyed about, disruptive behavior. So just be on the lookout for that. Before behaviors can be treated, the cause must be determined. So just because you wake up one day and Mrs. Smith is all confused, probably it's a UTI. So then they can treat the UTI. Or if it's a mental illness, then they'll have to go through the whole assessment until they arrive at a diagnosis. Pain, discomfort, frustration, physical needs. There can be personality conflicts. They can be environmental. They can be over or under stimulation, changes in relationship and interpersonal difficulties. So these are all things that can cause disruptive behaviors. Treatment for disruptive behaviors include correct perception problems, hearing. That sometimes it can be that they have a hearing loss, and you do not know that they cannot actually hear. So, and then if they wear hearing aids, make sure they always have hearing aids in. If they wear glasses, make sure they wear glasses. If personality conflicts, change caregivers. Sometimes residents may just not like they may just not like you. Don't take it personal. So just have another caregiver because if you force a caregiver onto a resident that does not want that caregiver, you will just worsen the situation. So the best is just to switch them out. And sometimes it can be the way you approach the resident that can cause, behaviors. So change the way you approach them. If it's in an overstimulated situation, offer some relaxation, warm bath, calm music, that sometimes can help. If they are understimulated, make sure they participate in activities, involve them into social activities. Have memory loss work for you, leave and re-enter. So in this situation, you have memory loss work for you, leave and re-enter. I don't know what that means. Okay, then we come to the dying of a resident. You will experience death in facilities because residents sometimes, they've lived their life and they'll die. So it's not something that should scare you. I know it's hard, but it's still something that you still need to take care of a resident even when they have died. I know in society we avoid the discussion of death and dying, but as a healthcare provider, this is something that you will not avoid. It will come at some stage. I remember my very first day of my very first job as a CNA, a resident died. The person who was training me had that resident, and that resident died on my very first day of my first CNA job. So at least I was on orientation. So I just watched the CNA. She was very calm, collected. She knew what to do, and I learned from her. Residents have got spiritual and religious concepts, so you just have to go with their religious beliefs and do not put your religious and spiritual beliefs onto them.
So when a resident dies, are the other residents aware of that?
Yeah, for the most part, they do put up the picture and like post it to say Mrs. So-and-so has died. And if family are going to come, if they share a room, sometimes what happens is that the other roommate is moved to another room until the family of that resident have been and paid their respects, and then the resident can be brought back into the room after the remains have been taken out of the room. Feelings and attitudes of family members, sometimes it's not very easy. Family members can react in not a very pleasant way towards the healthcare providers because their loved ones has died. It's a difficult situation. It's a difficult moment for everybody. So you just have to remain calm and positive. And sometimes all you can do is just sit and listen. I have so many stories of that. It's almost unbelievable, but it does happen. So you just have to remain calm. And if you cannot handle the situation, the best you can do is just step away and go report to the supervisor and let the supervisor know. Yeah, because sometimes family members are not, at that particular point in time, they cannot be very nice, but later on they'll come back to their senses and they'll come back and apologize. So as an NA provides support to the resident. I've talked about the types of reactions. Some NAs or some members of your team can cry and they just feel at a loss. You must recognize your own feelings, how to handle them, and past experiences and closeness to someone dying. Possible resident behavior when dying, they can be afraid, so just be there for support. They want to recover, but it's not possible. They may be asking a lot of questions. Yeah.
So when like the resident's dying and like the doctor, they know that they're gonna die, are residents aware of that?
Which residents? The other residents in the
No,
facility?
like,
The one who is the, oh yeah, they know. Because, if they have a terminal illness, say for instance, they have cancer, right? And they have so many days or weeks or months to live. The doctor has to be honest with them and just tell them. They know. It's just a different experience that you and I cannot describe, but the person who is dying has that experience that you and I will never understand. And some people can be resistant. They'll be like, oh no, I'm not gonna die. It's not me, it's not for me, it's for somebody else. There are stages of death, and one of it is denial. It's like, okay, oh no. And then you get into the bargaining where you, please God, let me live. I'll do everything possible. Anything that you want me to do, I will do. But at this point in time, I do not want to die. And then there's the acceptance stage where, it's a personal experience and it's so hard to describe. You and I cannot describe it, but the person who is dying is the person who experiences it. And then there are some family members that cause it so hard for a person to die. I remember taking care of a resident years back. He was dying and he knew it, but the wife was not ready. So she kept just telling him that he could not die and live. And it went on and on and on until one day the hospice nurse had to talk to her. Says, the more you keep him, the longer he will just be the way he is, because he's not gonna get better and get up and walk around. He's gonna die. But the more you hold on to him, the longer he will live, and it's not helping him and it's not helping you. The day she accepted that he could die, he died. Because she told him, it's okay, I'll be okay. You know, those are experiences that they are so personal that it's so hard to understand and believe, but they do happen. It's like, it's okay, I'll be fine. Okay, so they may complain frequently, they may make unreasonable requests, and some people just simply withdraw. They just close up to themselves until they die. They can cry, they can be sad, and they can get into denial.
We don't have a charge next.
Yeah, it's almost time. Yeah, let's see if we can quickly finish this. And we do not have any cleaning up to do today anyway. So be aware of residents' condition and how much they know. Listen to them, provide comfort and understanding. Encourage residents to talk about their feelings. Okay, don't stop them. Be truthful. If you know they're dying, just be truthful. But of course, being truthful does not mean you telling them, oh yeah, you're gonna die, right? You have to be comforting and be empathetic. Just tell them it's okay, you know. You have a loving family, they love you, we all love you. We spent a lot of good times together. Nice, comforting words, but at the same time, you're truthful that they're going to die. Sit with them, be there for them. Hospice care, I think we'll end here, and I think there are just a few more slides left. So they will be in the recording, and we can talk about hospice care and everything else that goes on. Then when we come back next week, Monday, I'll show the video on an Alzheimer's patient so that you can kind of get a picture of what happens with everything that we have talked about. Okay?
You don't want the video after the test?
So some residents who have a terminal illness or get into a situation where they will eventually pass on, they can have a service that is called hospice care. And the goal for this service is to allow natural and dignified as possible death, designed for individuals with terminal illness, like I said earlier. Hospice care focuses on the need and care of the terminally ill. It provides emotional and physical care and comfort for those who no longer pursue medical treatments. The hospice care services work with family to help them through the grieving process. Hospice care can also include day and night care as well as a 24-hour care. The death and dying, there are 5 stages of grief. There's denial, where a person just simply says that they do not want to die. There's also the stage of anger. They get very upset about the whole situation. And then sometimes they can get into a bargaining where they try to bargain and say if they were given some more time to live, they'll do everything possible to make things right. And then eventually they can get depressed about it. And at the end of it all, when all is said and done, they accept the situation that this is the end of their life and they'll pass on most likely very peacefully. We've talked about the do not resuscitate. The DNR is when a person has made it very clear to the healthcare providers and to the families that if anything should happen to them, they should not be revived at all. No CPR or no interventions that would prolong their lives. Living will, some people write what should be done to them and to their property when they have died. And a power of attorney is when they appoint somebody to take care of their medical needs when they become incapacitated. So if they cannot make decisions related to their health condition or medical condition, they have appointed somebody who would make decisions for them. What can you do? Try to be understanding of your own feeling. Follow the care plan. Keep room well ventilated, lighted at a comfortable temperature. Change residents' position often, at least every 2 hours. Keep resident beddings clean and as wrinkle-free as possible. Remember, with the wrinkled sheets, they can easily contribute to a rapid skin breakdown. And speak in a normal tone to resident, as the last sense in a human being to go is the sense of hearing. So even though they are not responding to you, or they are not talking back to you, or showing any signs of understanding anything that you're saying to them, still talk to them because they can still hear you. Respect residents' need for spiritual support. Encourage fluids. Do not force food. Frequent mouth care. If O2, if they have oxygen on, make sure you're doing a good nasal care. And then be supportive to both the resident and their families. Signs of approaching death. You will notice that their hands and their feet will become cold. The color around the extremities and around the mouth will change. It will be more of a bluish purple. Pupils will not react to or respond to light. Their respiration will be cold. And then sometimes you can hear the death rattle as they breathe in and out. They have a weak, rapid pulse. They'll be painful. They may become incontinent of both bowel and bladder, and they may have hallucinations. Immediate family needs. Family may wish to stay with the resident during cares. Some opt to step out of the room. Some may need privacy and spiritual support. Talk to the family, answer questions. And if you're not able to answer the question, at least refer them to someone who can. Make family comfortable as much as you can. Be courteous, understanding, and thoughtful families' feelings. Show them designated family areas where they can have privacy. Postmortem care. Once a resident has died, wait until the supervisor tells you to go ahead and do postmortem care. Treat body with respect and dignity and be gentle. This is an emotional time for family and staff, so just be conscientious of that. Facilities may have different procedures, so just follow what the procedure of your facility is. Postmortem care is given before rigor mortis sets in. This is when the body is still very flexible. Otherwise, when you take too long, the body will become stiff and it's hard for you to do a postmortem care. Postmortem care is given to help the mortician prepare the body for viewing. So once you've done postmortem in the facility, this also helps the mortician to prepare the body for viewing. Ensure privacy. When you do postmortem care, you can ask the family to step out unless they choose to stay. Close eyes if open. Put glasses on face or pillow. Replace dentures if possible, or put the clean dentures in a labeled cup with a resident's name on them, because when the mortician comes, they will the family may want the dentures to be put into their resident's mouth even though they've died. Clean and close the mouth, bathe the body, clean fingernails, put on a clean gown, comb the hair, shave if necessary. If a catheter needs to be removed, make sure that your nurse or whoever is taking care of them removes the catheter. And then remove all personal belongings and give them to the family or the supervisor. Other postmortem cares include fold arms over the abdomen, assure bed linens are clean and wrinkle-free, assist the mortician to gently remove the body to the stretcher, and remove bed linens and supplies to ready room for cleaning, because the room will be cleaned almost immediately after the remains of the resident have been removed from the room. So what you will need to, here are some of the review questions that I would like you to pay attention to. Make sure you know what the musculoskeletal system is, the gastrointestinal. These you will want to know the functions. Know the functions of the musculoskeletal, gastrointestinal, the urinary system, the nervous system, the cardiovascular system, and the respiratory system. Just make sure you know the functions. What to do when you're caring for a confused resident. What to do with a dying resident. As a person grows older, physical changes may occur. What are those physical changes? What symptoms can you see with a person who has got Alzheimer's? Sorry, I'll take that back. What symptoms can you see in a resident that has got Parkinson's? When you are caring for a resident who has got Alzheimer's, what approach can you use? What foods help with lessening of constipation? What is one of the most common chronic conditions that you might find in elderly residents? How is your communication? Communication method acknowledges that the residents' feelings and accept them to be true. What symptoms can you see with the person who has got congestive heart failure, and what can you do to help them? What is a cerebrovascular accident, and what do you think you can do to help? What is there in place that will help a resident who has had a stroke? We talked about the 5 stages of death. So what is one of the 5 stages of death? What do you think the resident might do when they are going through the stages of death? What is the term that is used for after death? When a resident with Alzheimer's cannot understand basic instructions, what can you do about that? What causes constipation? When giving catheter care to an uncircumcised male, what should you do? We've talked about that in clinical. Sorry, not in clinical, in lab. What can you do if a resident is confused? What causes confusion? What are some of the, other conditions that might cause confusion? You wake up, a resident wakes up one day and one morning and they're totally confused. What do you think would have caused that confusion? What causes mental illness to get worse? A resident with an ostomy, the nurse aide should pay attention to which of the following? What should you be paying attention to? The last sense that leaves the body. What is the last sense that leaves the body when a person is nearing death? What is the most common disease amongst elderly people who are more than 65 years old? And what can you do to help them? So those are some of the review questions that I would like you to look at as you study. And that marks the end of Unit 6. Good luck.